Good afternoon, everybody. Welcome to all of you, to all of our listeners and guests. I'm Ann Montgomery, Director of the Center for Elder Care Improvement at Altarum, and I feel very privileged to be here today with all of you. Our webinar is titled Flipping the Ageism Script, and it runs from 2 to 3 p.m. So today is going to be a lively conversation because we're going to be talking about the big picture that affects all of us, ageism, and we're also going to be talking about ableism. We'll start by defining ageism. It's an assumption, a prejudice, that older people are less competent, less important, and declining in abilities of all kinds. Ageism shows up in employment relatively early, with studies showing that it's harder for people as young as 40 to find work. Recruiting firms are sometimes prone to screening out older adults, perhaps because they think they can't contribute as much as a younger person for the same amount of money. And in healthcare, some studies suggest that older people don't receive all of the treatments that they could, independent of the severity of their health problems. During COVID-19, some hospitals outside the US actually used age cutoffs to ration ventilator use. And here, public discourse about not wearing masks sometimes devalued older people's lives, and there was a good bit of ageist dialogue online with trending hashtags like the infamous boomer remover. Taken to an extreme, ageism manifests in elder abuse, and we'll talk about that later with Bob Loncato. Ableism is discrimination and social prejudice against people with disabilities, and it's based on the belief that typical abilities are superior. It is rooted in the assumption that disabled people require fixing and defines people by their disability. Maurice Miller knows a lot about that. He's one of our panelists, and he will be addressing these issues from his perspective. Kezia Scales, another of our panelists, will help us understand the pivotal role played by direct care workers in healthcare who do so much to assist those who are older, like those who need help on a daily basis and live in nursing homes, and also those who live in their own homes safely and independently with help. There are younger people living in nursing homes like Maurice, who may have different goals for what they would like to be able to do in their lives. And with the right kind of assistance, they can do that. The question is, do they get it? And if not, what do we need to do to change that? The challenges faced by direct care workers are, as we know, very pronounced. And something that isn't really discussed as much as it should be is that the sector's low wages and poor benefits are worsened by discrimination and prejudice, including racism, sexism, and anti-immigrant bias, since the direct care workforce is comprised mainly of women, persons of color, and immigrants. We talked some about this in our first webinar in this series of 3, and we'll revisit some of the intersections of these challenges and barriers along with the themes that we're discussing today. In terms of solutions, we're going to try to have a larger conversation about tearing down walls. Remember when John F. Kennedy said he was in spirit a Berlin citizen in June of 1963, and that all Germans had a right to be free? And when Ronald Reagan called for tearing down the Berlin Wall 24 years later in June of 1987, and then it happened in November 1989, those are seminal moments, and they're not accidental. Each of them happened due to unique but related circumstances. And now it's time to talk about other kinds of walls that we need to deconstruct, that for the most part are not tangible and which close off opportunity. The walls of racism and of gender inequity, of ageism and ableism. And we're really fortunate to have some outstanding people here today to reflect on all of this. So first we'll turn to Kezia Scales, who's Director of Policy Research at PHI, and she'll talk about the long-term care workforce and why it matters so much at this juncture. It's a workforce that has long been devalued, and with any luck, we're about to see that start to shift. States are beginning to enact wage raises. Rhode Island is the most recent state I'm aware of to enact a law that establishes staffing standards in nursing homes and also requires that a percentage of Medicaid reimbursement increases be used for wage increases for direct care workers. That sounds like progress, and what our colleague at the first webinar, Henrietta Ivey of Black Women in Home Care, called for, which she abbreviated as RPP, or Respect, Protect, and Pay Us. So we look forward to hearing from Kezia. Next, we'll have Maurice Miller reflect on his experiences and perspectives as a journalist living with disability in a nursing home here in the Washington, D.C. area. Maurice also shared that he is a native of Michigan, which is tremendous because Altarum is headquartered in Ann Arbor. And Maurice is an advocate and a Medicare and Medicaid beneficiary So he understands the limitations and the advantages of those programs in his lived experience. And finally, we'll have Bob Lancato join us. He's coming at 2:15, who's a star in many ways, and the list of things he's done in his career and is doing now is very long. Among his talents, Bob is a movement builder and someone who knows how to organize and how to motivate, and that is a major part of what he brings here today. He runs the Elder Justice Coalition, which he built pretty much by himself, and which I believe has hundreds of organizations and individuals who are participating. He's also organized a couple of White House conferences on aging. Those are massive national efforts to get everybody in the country talking about improving the experiences of aging. I hope we have one of those again soon. To read more about Bob and Maurice and Kezia, you can take a look at our website, and I'm sure they would be happy to follow up if you have questions that we can't get to today with email responses, and so would we. And after we hear from Kezia and Maurice and Bob, we'll go to questions from you and also a few from me to start off with as moderator for the audience. So let's get started. Kezia.
Great. Thank you so much, Anne. And thank you to Altarum for the opportunity to participate in this really important conversation. So as Anne mentioned, I'm the Director of Policy Research for PHI, which is a national research, consulting, and advocacy organization that's dedicated to promoting quality jobs for direct care workers as the foundation of quality care for older adults and people with disabilities. And by direct care workers, I mean the 4.6 million plus personal care aides, home health aides, and nursing assistants who are the front line of paid care across settings, from private homes to community settings to residential care and nursing homes and beyond. And where I'm coming from on this conversation is that if we are going to flip the script on ageism and on ableism, if we're talking about older adults and people with disabilities being fully enabled and engaged, then we need to flip the script on caregiving as well. Because the ability to live and thrive throughout life and in older age depends in part, for many of us, on being able to access high quality supports and services when and where we need them, without becoming impoverished, without being stigmatized or marginalized or isolated, and without having to over-rely on family caregivers who play such an important role. And to substantiate that point with some recent estimates, the number of older adults with significant disabilities, meaning disabilities that require some degree of long-term care, will double from now until 2065, from 7.2 million older adults with significant disabilities to almost 14.3 million. Over half of those turning 65 in the US today will develop a significant disability at some point in their lives. That's 56%. And nearly half, 47%, will rely on paid services. So we need a strong and stable long-term services and support system as one aspect of combating ageism and ableism. And that means we need a strong, stable, direct care workforce. And that point is borne out by the employment projections for direct care. Direct care is expected to add 1.3 million additional jobs. That's new jobs in the next decade, from 2019 to 2029. That's more new jobs than any other occupation in our country, across industry, across sector. But we will also have to fill an additional 6.2 million job openings in the same decade as workers leave the field for other occupations or leave the labor force altogether. And we're already facing high rates of turnover and job vacancy rates across long-term care, leading to inconsistent care or unmet needs. So we need to flip the script on caregiving to address this mismatch, to ensure that our country's care infrastructure can support the growing needs of our population. So I want to start from a sort of strengths-based approach, an action-oriented approach, by presenting 3 recommendations for immediate action. Because now, as Anne was getting at in her introduction, now is the time. Now is the time for action because we're emerging from a public health crisis that has brought to light, with devastating consequences, the fragility and fragmentation and frankly, the inadequacy of our current long-term care system. And now is the time for action because we're also talking as a society about race and about how disparities due to race and ethnicity and other intersecting identities play out in health and well-being and employment and longevity and opportunity and in so many other ways. And direct care workers and those that they serve stand at the intersection of all of this. Direct care workers, because as Anne said, they are predominantly women and people of color and immigrants surviving on near poverty level wages and public assistance in many cases, often without support for their own health or caregiving needs. They have been undervalued and overlooked for far too long. And this past year showed us that this must change. And older adults and people with disabilities who need long-term services and supports are also at this intersection, because among them, there are huge inequities in access to and the quality and outcome of services depending on race and ethnicity and economic status, among other variables. And again, we saw those inequities revealed during the pandemic, and we should not unsee them. So here are my recommendations for what should happen right now, before we forget, before we move on from this moment, to strengthen our long-term care system, bolster direct care jobs, and address the cross-cutting inequities that hold us all back. First of all, I would say that we need to fix long-term care financing to ensure access for services for those who need them and to transform direct care jobs. The $400 billion investment in home and community-based services that is part of Biden's full infrastructure plan would make an unparalleled impact here. So too would the HCBS Access Act, a draft bill that would make HCBS a mandatory Medicaid benefit in every state and help build the HCBS infrastructure and workforce. But going further, I would suggest we need to move away from our dependence on Medicaid as the primary payer of long-term care and toward a universal social insurance model that everyone pays into to the extent that they can and everyone benefits from if and when needed. That's what we need for sustainability, and also to overcome the huge divisions that we have now between who can afford services and who can't, who gets help when they need it and who doesn't, whose wages are paid by Medicaid and whose aren't. There's one proposal already out there called the WISH Act. That stands for Wellbeing Insurance for Seniors to Be at Home Act. And it would introduce a social insurance program at the national level to make home care more affordable for more people. And in the process of fixing our financing approach to long-term care, which I know is no mean feat, we need to build in good jobs for direct care workers. That means honestly calculating the cost of services to include the full costs of labor, a living wage, adequate benefits, entry-level and ongoing training, and wage tiers to match higher levels of training and responsibility. This sounds like a lot to ask from where we're starting from when I list it out like that, but it's what we expect of most occupations already. Why not direct care, one of the most important jobs that we have? Guidance on this calculation, I would say, should come from the federal level, and requirements should be built into all public payment contracts at the very minimum. My second recommendation is that we need to strengthen the training landscape for direct care workers and for home care workers in particular, as health and long-term care services move more and more into the community. One key action here is to establish a minimum federal training standard for personal care aides, just like for home health aides and nursing assistants. Personal care aides are such a significant proportion of this workforce, but they're currently subject to only a patchwork of largely inadequate training requirements at the state or program level only, or no training standards at all. And that means they're not consistently prepared as a workforce, but it also obscures their value. Because how important can this work be if it doesn't require training or qualifications? Well, it's undeniably important, but that's not reflected in the current regulations. Another more ambitious action here would be to convene a task force at the federal level to really get to grips with the training landscape for direct care and develop recommendations and guidance for states on how to move toward comprehensive competency-based training standards for direct care workers that lead to meaningful credentials that are portable from one job to another and stackable to allow more career mobility. There's already such good thinking and good examples out there on this. We just need leadership and commitment to carry this work forward. And in terms of this being the moment to take action, there are a number of federal bills already in circulation that would support and boost training for direct care workers. Two examples are the Direct Support Worker Training Reimbursement Act and the Molly Baldwin Upskilling of Personal and Home Care Aides Act. And my third recommendation is that we need to invest more efforts in creating and evaluating advanced roles for direct care workers. I'm talking here about building rungs into the career ladder for direct care so that we can maximize the skills and experience of those who thrive in this work, those who want to remain in and progress in this work. Examples of advanced roles include senior aides who can support care coordination or care transitions or provide care for specific conditions or populations. There's also peer mentor roles and training support roles and more. And there are some really good examples out there in practice, but we need better evidence. We need more evidence on the implementation and outcomes of advanced roles, how they affect job satisfaction and intent to stay, how they reduce costs associated with turnover, and how they improve care processes and outcomes. And there's legislation out there about this too. As one example, the Direct Care Opportunity Act, which is the Direct Creation, Advancement, and Retention of Employment Opportunity Act, proposes to invest more than $1 billion over 5 years in direct care workforce interventions, including career advancement opportunities. So with these recommendations and other changes, I would say we are flipping the script on caregiving. We are affirming in structural ways that direct care workers matter, that they make a valuable contribution, and that they merit adequate training, compensation, and opportunities to advance. We're creating career-worthy jobs, and as a result, a more flexible and a more stable workforce. And we're helping ensure that older adults and people with disabilities can receive care that is technically proficient, culturally competent, and person-centered. That, looping back around to the description of today's webinar, is essential for supporting their ability to continue contributing to their families and communities and to society at large. Thank you.
Thank you, Kezia. That was amazing. It gives us lots to think about, and I took a lot of notes. All right, we'll go to Maurice now.
Thank you, Anne. I appreciate this opportunity to speak. I essentially would like to say that I'm on a crusade to dismantle the long-term nursing care system as we know it, and to replace it with a human care system instead of the commodities-based system that we see today. And I'd like to give you a couple of examples of why that needs to be. When you come into the door, you might, as I was and as many other people have, be offered what is called a nursing home insurance plan. It sounds great. There are a number of benefits to it. But as we learned during the pandemic, you have no virtual care benefits. And as you are aware, the most vulnerable population during this recent pandemic were nursing home residents. So there we are, forced to pack up, schlep out, and risk becoming more infected in order to get outside care where everyone else was being able to take advantage of virtual visits, which were highly recommended during the height of the pandemic. And this affected a lot of people, a lot of elderly people who didn't need to be going out into the wild, as it were. In 2017, I was finally diagnosed as a full-blown diabetic. I was probed and prodded, given lots of finger sticks, and given lots of shots, and there was no announcement made to me why that was happening. I discontinued all of that and said, I need to speak to a physician before you do any more. The physician came to me and I said, you don't start doing these things without talking to me first. You have to do that. And he said, oh, we regularly treat people without informing them of the. I said, you don't do that to me. The fact that he can make that statement so openly and blatantly showed a pattern of recklessness and indifference to the people that they were supposed to care for, many of whom, most of whom, were elderly people. I have been diagnosed with a number of non-pressure related wounds. I was told by the wound care team, multiple iterations of wound care teams here at the facility, that they had to do with, quote, an autoimmune disorder common among African Americans. Well, later on, I decided to have myself treated outside by a wound care clinic with a board certified physician. It turned out that the correct diagnosis was that my wounds were all moisture related. I sweat a lot. It had nothing to do with any autoimmune disorder. Um, I live in a majority minority nursing home. It's critical not to jump to conclusions based upon ethnicity. Um, and when you are doing that, and people are not able to advocate for themselves, as I was, what you are doing is placing people in harm's way. On top of that, one of the wounds needs further extensive surgical treatment because of a misdiagnosis that the team here had. And part of the diagnosis that they missed, part of the reason they missed the diagnosis was directly due to my disability. They were too lazy to turn me over properly, which the wound care clinic did. And they were able to closely observe the wounds. If you're not able to treat your disabled patients properly, you're going to miss a lot. And I made it clear to them, you blew the diagnosis. They want to account for that. They want to accept accountability for that. But that's it at the bottom line. Then there is my favorite one. I'm a functional quadriplegic. I have literally written tens of thousands of words to the facility staff, on my social media posts, and every single one of my emails, including my emails in coordinating my presence here at this webinar via speech to text software. And not a single word has been composed um, with my hands. So when I had a procedure done on my larynx, and I called in advance to the executive director of the facility to say I was not going to be able to speak for about 2 days, and to please pass the word on to that nursing team and all the people who were going to treat me. My family member who had accompanied me to the appointment and the ENT physician who was treating me were stupefied, and I was not at all shocked when the executive director said, oh, that's okay. He can just press this emergency button, and when the GNA comes into the room, he can type what he needs on his computer. And I had to correct him and say, well, we can't do that because I'm still going to be a functional quadriplegic. These are the things that we as disabled people and as elderly people face currently in this commodity-based system where we are treated as It would implies commodities, where healthcare, one word, is being practiced instead of health care, two words. Now, what do we do to solve this problem? First and foremost, I've been asked to talk about the person-to-person interaction. And a matter of fact, the person-to-person interaction is quite fine. We have dedicated people that care about us. These people are people who went through the pandemic with us, who risked their lives to save our lives. The problem is they are so sick and tired of dealing with the management structures that they have to deal with. They may survive the pandemic, but not survive dealing with the people they have to deal with after the pandemic. They need help. And the fact that they need help is causing tension between them and us. So we need to ease that tension. How do we do that? We need to get them more help. We need to get more people involved in treating the residents. That means we need to lobby the legislatures to get busy with indexing the care, the number of people involved in our care to medically realistic numbers, not the minimum. The minimums are substandard. You have to come out and say that. Um, the minimums do not allow people to respond to call lights in a timely fashion. We all know by the science that a major coronary event needs to be responded to in less than 6 minutes. When the call light is hit and you have to wait 2 hours for a response, that means that there's no hope for a medical emergency to be treated in a timely fashion. Um, we need to be realistic in our approach to a $15 an hour minimum wage. Kesey has suggested a number of other things, but I think we need to start basically from scratch. A $15 minimum wage push needs to be segmented. I believe essential care healthcare workers need to be put at the top of the list, then essential care workers, and then everybody else. I don't think anyone will argue, based on what we have seen in this pandemic, that healthcare workers have to get a priority, and that our healthcare system and our healthcare workers need to be taken care of. Thirdly, I think we need to discuss what is happening within our nursing communities. These are controlled environments where the diseases that we can control should be controlled. We are in a situation where there's no alcohol abuse, there's no drug abuse, the diets are controlled. So why aren't the diabetes numbers going down? Why aren't the blood pressure numbers going down? In other words, why can't we reduce the number of medications prescribed, um, the heart disease numbers that we face, the number of amount of insulin we use? Why can't we in nursing homes reduce the strain on the safety nets and thereby provide more resources to other parts of the safety net? There's an answer there somewhere, and we need to find that answer. I know part of that answer is that there's a disincentive to make people in nursing homes healthier because there is an incentive to profit off of their illnesses. Nursing homes charge exorbitant amounts just to provide a finger stick to each resident, and some residents have to have 3 and 4 finger sticks per day. That's profiting off a person's illness instead of benefiting off their wellness. Yes, there needs to also be tax incentives. so that these nursing homes management companies would decide that they will want to do something better for their people that they take care of. I'll just say this in conclusion, because I can go on and on and on, because, like the person in network, I'm mad as hell. I can't take this anymore. I believe that each one of you out there and the management company and the members of the management companies that are running these nursing homes may not realize it, but you are one catastrophic event away from residing in a nursing home yourself. And that thought should terrify you. And that thought should also incent you to want to do something now to make the system better for our reality now and for your future. Thank you.
Thank you, Maurice. That was pretty amazing. I think that these messages are going to be picked up and carried forward a long way. And now it's my great pleasure to hear from Bob Blancato. Bob, welcome. I already gave the introduction. Your CV is too long for me to go through the whole thing. It's amazing, but
No,
I know
please don't do that. No.
and
Well, Maurice, I have to tell you, I listened with great interest. Your perspective is very important. I have a few things to connect to that. But I want to first say thank you, Ann, for the invitation. And, I have to say, I saw the title, Flipping the Ageism Script. And as an old New Yorker, I have a better way of saying it. Let's flip the bird on ageism. I think that's what we need to be talking about here. Because, this is a topic I have lived with for 40 years on a professional and personal basis. I've worked in aging policy for 40 years, and I've added 40 years to my life. And I see some progress, but I still see us arguing over the same thing. Okay, we've made progress. We've done things like end mandatory retirement. We have a family caregiver support program. We have money follows the person. We had the Affordable Care Act and how it strengthened Medicare. Okay, and funding for the Elder Justice Act, which I know we'll talk about later. But then we have the old arguments: quality of care, long-term services and supports. And even with caregivers, what do we have? We have one program and $150 million for the whole country as the response to the needs for caregiving. That's not anywhere near enough. And nursing home reform, as Maurice just talked about. And of course, we have the ongoing issue of age discrimination in the workplace. That remains the case. And, I've always believed, and I still do, that a lot of what promotes ageism in this country is denial. Okay. It's the last ism to be recognized. It's the one that most people could be impacted by, if you think about it. And, I've seen where it's been promoted by pitting generations against each other instead of promoting intergenerational activities. Older adults take too much, according to the generation pitters. Okay, they never talk about what they give back and what they've done to strengthen the society. Groups like Generations United have done a good job to help bridge that gap. But I think what we have to start thinking about is how we look at aging as a lifespan issue, period, and approach our solutions in that way. And, I think the best current example we can think about, and the one that we should all be advocating for as vigorously as we can, is the president's proposal for $400 billion for home and community-based care. It's investing in what older people, persons with disabilities and their families prefer, that type of care. It would allow us to continue the rebalancing of Medicaid away from funding institutional care and more home and community-based care. We have other things we could do. There's a bill in Congress that Congressman Bobby Scott has championed, the Older Workers Against Discrimination Act. Okay, aligning the burden of proof in age discrimination cases with the same standards for proving discrimination that you do based on race, sex, or national origin. And hopefully, let's think about reauthorizing the Elder Justice Act, which I know we'll cover a little bit later. And finally, just in terms of opening thoughts, lifelong disadvantages have to be considered, or we have to consider the recognition of longevity when addressing equity. There is a relationship between the two. And I think about one example, and I'm sure the country knows what I'm going to say when I mention the name. 107-year-old Viola Fletcher, one of the survivors of the Tulsa massacre. But one has to wonder, what else has she endured in her long life as an older person of color? And for those who've endured these issues longer, shouldn't our solutions work faster for them? And when we get to the nursing home thing, I certainly will have some other thoughts on that too, but I'm just very happy that to join you today and be part of this discussion.
Well, thank you, Bob, and thank you, Kezia, and thank you, Maurice, for absolutely outstanding and provocative remarks. And I'm really glad we're recording this so I can go back and listen to it later. So now we'll turn to our discussion, and I'll kick off with a couple of questions that I thought of. We also have a Q&A icon at the bottom. Hopefully you've discovered that, all of you out there, and please seed it with as many questions as you can think of. As you can tell, these are people who are candid and who are able to take on tough issues. And that's something that we probably all have in common. So I'm going to start, Maurice, with your observation about raising wages to $15 an hour for long-term care workers, essential workers. And you seem to suggest that you think that's the highest priority in terms of recommendations, or among the highest priorities for taking that forward. So I don't know if you're aware of what the wages are that are being paid for CNAs, certified nurse aides in your home, but if the wage rate were increased to $15 an hour, what do you think would happen? How might that change things? Just some reflections on that would be great to hear from you.
I think it would be a starting point for not just my nursing home, where the wages approximate that the starting wages come close to that. It's about $2 less than that. But I'm advocating that across the board because I've been in touch. I've seen the presentation from the advocacy group for CNAs in general, and I know that some of the wages are as low as $7 an hour. So an increase to $15 an hour is definitely a living wage. And the head of the advocacy group for CNAs speaks more powerfully to this and talks about how the people who care for us and who save our lives, literally, and are trained to save our lives, themselves are living in their cars frequently, and that's not acceptable. These people literally are certified to save our lives in emergencies. They are life givers, they're life savers, and they need to be treated as such. So I believe that there are inequities um, in across the board and imbalances in terms of who gets what, who gets paid what, and that needs to be straightened out. That's why I believe that healthcare workers need to have that standard first and foremost, and I think that everyone could agree to that. There's pushback to an overall $15 an hour minimum wage, but I think we can all agree that our healthcare people, our first line of defense for everybody, deserves that minimum.
I don't think you'll get disagreement from anybody here. I think you're absolutely right. So thank you for that. Kezia, I wonder what you think of that. And also I'd be very interested, I think we all would, in hearing your thoughts about the training. You mentioned that it really should be portable and stackable. And I thought that was a really interesting way to phrase it, because I believe that states are kind of isolating in their credentials at the moment. And of course, there aren't even any credentials at the national level that I know of for personal and home care aides. So could you just say more about those issues and how you think they all intertwine?
Sure, thank you. Well, I would definitely echo what Maurice was saying about the importance of wages for this workforce. And I really like the point that not only do these have to be living wages, but they have to be competitive relative to other sectors and industries, because we need to elevate these jobs. We need to lift them up higher and make them jobs that people are called to do and want to do and can afford to do and sustain. So I think that's absolutely right. And we need to keep pushing for that no matter what. But also thinking about wages and compensation overall being one part of a multifaceted puzzle around job quality and strengthening and stabilizing this workforce. And I think training is another key piece of that, as you say, Anne. I think what we have right now is this incredibly fragmented and inconsistent training landscape for the full direct care workforce. So different training standards for nursing assistants and home health aides, which are set at the federal level at 75 hours minimum, which is a very low minimum. I think we could agree for the complexity and importance of this work, but no federal training standard for personal care aides. That's devolved to the state level. Some states have statewide regulations, others don't. Some have only regulations within particular Medicaid programs or for particular settings of service. And what ends up happening is that we have a very inefficient system when what we need is the most efficient system possible to make sure that we are matching our workforce with those who need services. So, I might get a job in a particular state as a personal care aide. When that job comes to an end, because for example, I'm no longer working with the client I was matched with, or for another reason, there's nothing necessarily that I can take with me from that job to the next job in terms of a recognized credential or set of skills or experiences. So it's sort of like I'm continuing to start from scratch every time I move into a different direct care job. What we need instead, I think the ideal vision is an understanding that there are core competencies that are required to do this job well, no matter where you're working or who you're working with. There's basic foundational core competencies. And then there are additional competencies that are needed if you are working in a particular care setting, or if you are working with individuals with particular conditions, for example. And in the ideal sense, or in the ideal scenario, we would have training that would ensure that everybody in a direct care role is trained to those core competencies, and that they have then opportunities to do more training to attain additional competencies with credentials that they can carry with them. So they can say from one employer to another, or one Medicaid program to another, or even maybe across states, I've done this training, I have this competency, and they can sort of continue moving along in their career instead of, as I say, continuing to have to kind of go back and start from scratch again. And then ultimately, the idea is that you could continue to pursue additional training, take on new skills, be able to work in new settings or work with new populations, and keep your work as varied as you want it to be as a direct care worker. You have that career mobility for yourself. And we also have a workforce that is much more flexible and able to be deployed where it's needed the most as the system evolves.
And if I can just dovetail slightly into what Kezia just said, one key thing in all of this, and in developing skills and core competencies and adding to the wage, is that we have to make sure that what we're developing in the opportunities is something that will allow people to love their work. If it comes across as um, a rote opportunity or a rote job, where you're just changing diapers or changing T2 tubes, there's no amount of interest. There's no interest. There'll be disinterest in doing the job. Um, they have to be able to be engaged in their jobs. That's why they claim that young people are not interested in doing this work, and that there's a, 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 a gap in the number of people trying to get into this work because of the low wages and because of the type of work they think they're going to be doing. So we have to be able to make this fascinating work. And I think that's what's missing right now. And what Kezia is talking about is right on point. Um, if you make the, if you give people the right training and then you engage them in what they're doing and make them active participants in it, that's they realize that they're doing good work, and that's what's important, no matter what field you're in.
You know,
Very well said. Bob, what do you think about this?
I mean, I agree with everything that people are saying, and and going back to your Senate days, when we were dealing early on with the Elder Justice Act, the whole issue of staffing was front and center in the original Elder Justice, providing incentives for hiring and retaining qualified staff in nursing homes, using the tax code for something positive. Okay, provide tax incentives, but at the flip side, what we fail to do sometimes, and I'm always confused why we don't put that hammer on like we should, which is there should be a relationship between the quality of staffing and your ability to participate in Medicare and Medicaid. I mean, we don't tie enough to the conditions for Medicare and Medicaid. I mean, that's an incentive for people to go into the business of owning nursing homes, but it doesn't necessarily translate into the quality side. So we really do need it. And Maurice was right. The private equity involvement in nursing homes is disturbing because of what has happened to the quality of care in a lot of the places where they've acquired it. I mean, I've testified twice just before the pandemic on this very issue in Ways and Means and Finance. And, the cynical part of people who follow this thing and said they buy those nursing homes for the land. They don't care about the facility. They don't care about what goes inside the facility. They're going to buy it for the land and then turn it over and they will make money just from that alone. That's wrong. There has got to be both the positive, so the incentives, and some hammer like participation in Medicare, Medicaid for us to really address staffing going forward.
Yes, couldn't agree more. And I think probably a lot of people who are watching are working on, staffing ideas. How can you tie, Medicare reimbursement, Medicaid reimbursement to good staffing, which we already know really what that is. And we defined it quantitatively 20 years ago as 4.1 hours of care at a minimum per day per resident. And yet we don't insist on it. We don't even make it clear on Nursing Home Compare,
Right.
Nor do we provide data on turnover and these kinds of sort of factors that don't make it clear to people, I think allow nursing homes who don't necessarily want to do a good job to kind of get away with it. So we should cut that out.
And one other thing that you remember when they put out the Elder Justice Roadmap that was done by the Department of Justice about 10, 12 years ago, they said residents of understaffed nursing homes are 22% more likely to be admitted to hospitals due to neglect. Bingo. I mean, it's right there. It's in statistical data. But, it is, and he's right. Morris is right, and Keisha's right about, making it a quality job too. Quality care is one thing, but have quality job is another, and they go together, frankly.
Mm-hmm. Excellent. All right, Bob, so I have a question on elder abuse. Since the start of COVID-19, there's been a massive increase, unfortunately, in reports of elder abuse, probably because of ageism and devaluing of older people. They range from incidents of family violence to neglect and financial scams in people's homes and nursing homes all over the place. And this has prompted the Federal Trade Commission, the American Bar Association, and state departments to issue warnings to the public. And there have been deeply distressing reports of older people who were really abandoned, actually, in long-term care homes in Spain and in Canada. So things have not been good. And I alluded to earlier in Italy, actually, where 23% of the population is 65 and older. That's where some hospitals apparently decided to use age cutoffs to ration ventilators. So we have a lot of work to do to correct assumptions. And we have a question from Judy Perez that kind of goes to this. What kind of larger societal changes can we envision and advocacy efforts that kind of keep going? You have a lot of experience with that in the Elder Justice Coalition to basically call this out as unacceptable in its many manifestations, as well as those that affect younger people with disabilities, and make a big stink about it, basically. What are your thoughts on
Yeah,
that?
well, I have too many thoughts for 8 minutes here, but let's just say, first of all, you're talking about the increases that we know about. There are so many unreported cases that we don't know about. Remember on the Senate Special Committee on Aging, for every one case of elder abuse that's reported, there's 5 cases that go unreported. That has not changed. It's probably gotten worse to some extent. But what has made it more disturbing is when you do find out the kinds of abuse cases that have occurred during the pandemic, the one that comes out and just gets at me in the worst way were the vaccine scams that they directed against older people. When the vaccine started to come out and they started being made available, within days of that, you had the scam artists out there coming up with these crazy things, calling older adults, you know, telling them that they could go here and get a vaccine, this and that, and this and that. It turned out never to be true. Okay. And to some extent, I think that prompted Congress back in December and again in March, and the third pandemic relief bill, and then the final one, the American Rescue Plan. The Elder Justice Act, prior to December of 2020, had gotten $70 million in funding over 10 years. Between December and March, it got $376 million in funding. And that's directed to adult protective services and long-term care ombudsman, in part to direct efforts at combating the scams, direct the efforts at helping to prevent other victimization from occurring, being able to be prepared, because what we got to worry about in elder abuse, as we do with child abuse, is the downstream. When the pandemic does reside and things do calm down, there'll be a ton more reports probably coming out, because you can report to somebody, which you haven't been able to do for some period of time. So, you know, but to the question about advocacy, and this is something that I've always believed in, there is no good policy without politics. Okay, if you don't make something a political issue in a meaningful way that motivates people to either be rewarded for doing the right thing or be electorally penalized for doing the wrong thing or not doing anything, we got to put elder abuse and elder justice in that space. Okay, because I give enormous credit to the child abuse advocates. They got a law passed in 1974 that's given them $9 billion in funding to help prevent child abuse. Family violence prevention, okay, passed in the mid 80s, has gotten, you know, $7 or $8 billion. And the Violence Against Women Act since 1992 has picked up almost $3 billion in funding. But they were dedicated advocates. They raised the issue, you know, and they also had champions. You got to remember, it's very important. I know Keisha knows this and Maurice knows this. You've got to have your champion lined up early, and they have to fight like hell, okay, to get, you know, to make these things an issue. And, you know, we have them luckily in the elder justice space. We just need more of them. And honestly, you can't limit yourself to just the people who pass laws. You need to have as your champions, people give money, okay? You can authorize all you want, okay? Authorizations are what you want, but appropriations are what you get. And that's where you have to spend some time working. So that's part of our strategy going forward. We're very grateful for this increase in funding, but the one thing we want to avoid in any of these situations is we want to avoid the cliff. The cliff comes when you have money and you lead more people get services or help, and then all of a sudden it goes away. And what happens to them? We can't afford to have that happen here.
Thank you for that. So Kesey, we have a question for you, and it's about many workers, direct care workers, especially women, had to stop working during the pandemic because schools and childcare centers shut down. And so that made it much more difficult to find paid childcare to replace closed schools. And it was, you know, a lot of the alternatives were priced outside their ability to find alternatives. So should childcare and long-term services towards workforce improvements be linked in some way?
Yeah, thank you for that question. And there is already such good work done on this, the idea of universal family care, the idea that these issues are so closely linked together. I think that's absolutely right. I think we should be thinking about them and talking about them at the same time and in interrelated ways. And I think that we also do need sort of targeted efforts on both. And so, you know, for example, something promising would be the Families Plan as proposed would be access to free or affordable childcare for those who need it. that's something that our direct care workers absolutely need in order to be able to sustain their own jobs and often really struggle to, to obtain. So I would just agree with the idea that these issues are very, very connected when you're thinking about a workforce that is predominantly women, and many of whom have children at home and are also, in many cases, I think about 10%, our estimates are about 10% of direct care workers also have someone like so they're grappling with their own caregiving challenges, even as they're trying to serve in the paid caregiving role. So we do need to think about these issues.
So where would we find out about universal family care if somebody wanted to learn about it? Where would they go?
Let me do a quick, I'll put something in the chat.
In the chat? Okay, great. All right, and I think we're gonna ask Maurice a question, then I'll probably wrap up. So here's a question, Maurice, for you from Robert Schreiber. Is there a way to have your voice and others heard by nursing home staff and leaders to focus on the approach that you are advocating for? Are you part of a resident advisory committee? And what impact and input does that committee have? Your approach is very person-centered and directed, and that's what we all need to advocate for. Thank you for your perspective and setting the bar high for what is needed.
Yes, as a matter of fact, I'm part of the advocacy group known as Consumer Voice, which is the group that advocates in behalf of long-term care residents. It's, as a matter of fact, the group that helped get me in touch with Anne and helped me participate in this webinar. They are the group that I'm going to link up with to help me to promote some of the things that I've said. And I hope that we're going to be able to push forward some of the things that I said. The concept of being one catastrophic event away from being in a nursing home facility is going to be a hashtag that I'm going to hopefully have trending through our group. And it's going to be simply hashtag the #1 away. And I hope that we will be able to make that a trend, make that a trending thing on social media platforms all over. Because I believe it's true. And I believe that that is the way to engage everyone, regardless of their others' position on the political spectrum, in improving the quality of long-term care. So you can reach out to Consumer Voice. You can help us in our work. And please do. And I'd like to thank them for, as always, helping me to connect with places where I can speak my voice.
Well, thank you all. And Consumer Voice is an outstanding organization, as is PHI and the Elder Justice Coalition. So this gathering is a very special one to me, and I think probably many other people. It brings to a close our webinar series, which has featured some very wide-ranging discussions all about equity. And I want to thank each of you here today, Kezia, Maurice, and Bob, and also those who appeared earlier, Debbie Dingle, Robin Stone, Henrietta Ivy, Allison Barkoff, Tyree Brown, Jean Axe, who graced our first 2 webinars. All of you are dedicated to flipping the script on the isms, our care delivery systems and our civil society more generally. Clearly, you are inspiring and helping us to move forward to do even more. So we want to take what you said forward in solidarity. Thank you all for being here, presenters and all of our colleagues watching, and for the work that you do. Have a fabulous afternoon. Bye-bye.